We are your hosts, Nicki Shorr and Jessie Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hi, Nicki. How are you?
You know, as always, I'm getting by and doing well. How about you, Jess?
Fantastic. Thank you. So as always, I'm extremely happy to be here talking with you and our guest today. But before we get started, I have a fresh joke for you.
Oh boy. Okay.
What types of flowers do bacteria like?
Okay. Oh, I don't know. What?
Germaniums, of course.
Bum. Oh, it's always good to start off a joke with you.
I agree. So today we welcome Dr. Marybeth Sexton to the show. Dr. Sexton is Chief Quality Officer at Emory Clinic and ESA and is an epidemiologist at the Emory Clinic and serves as Assistant Professor within the Division of Infectious Diseases at Emory University. So Dr. Sexton is joining us today to talk about her research article, Risk Factors for Isolation of Carbapenem-Resistant Enterobacterales from Normally Sterile Sites and Urine. So welcome, Dr. Sexton, and thank you so much for being here with us today.
Thanks so much for having me.
So can you just get us started today by giving us a little bit of background on what prompted the study?
Sure. So the group of researchers who conducted the study was working as part of the Georgia Emerging Infections Program under the Centers for Disease Control programs nationally that collect data on pathogens of particular interest, of which CRE has been one because of its significant consequences for patient morbidity and mortality, given the limited number of antibiotics available for treatment. And so what we decided to do was to look at the data from the Atlanta metro area Georgia Emerging Infections Program cohort from August of 2011 through December of 2015 to look at patients with CRE and to compare those who had CRE present just in their urine to those who had an invasive infection at a normally sterile site, and to evaluate what were the risk factors for having those invasive infections, because in certain studies prior to this, those had mortality rates up to 50%.
So maybe we should start by giving a little background on CREs and which organisms were included in the study. And also, if you wouldn't mind giving us what resistance patterns were included in the study.
Sure, absolutely. So CRE is our broad spectrum category of our carbapenem-resistant Enterobacterales for the purposes of the Emerging Infections Program, looking at E. coli, Klebsiella species, and Enterobacter species that were carbapenem non-susceptible. Although at the time this study was done, that did exclude things that were solely non-susceptible to ertapenem, and that was the Emerging Infections Program definition nationally, and that were non-susceptible to all tested third-generation cephalosporins.
And that includes ertapenem now, right? The definition now includes ertapenem?
It has changed since the end of this study.
Okay, so in the article, it talks about the increased risk for patients who may have an indwelling catheter or device and the importance of rapid removal of those devices. So as part of the investigation, did you discover anything regarding current practices at the participating hospitals with regard to like how long these devices were maintained?
No, so the way that the Georgia Emerging Infections Program collects the data is that it's a retrospective surveillance based on isolates submitted to 23 participating laboratories that cover doctors' offices, healthcare facilities and hospitals in the 8-county metropolitan area. So there's a very large number of facilities potentially contributing data to this cohort. We did definitely find that the strongest associations with having an invasive infection as opposed to having CRE simply present in the urine were having a central venous catheter, having some sort of other indwelling invasive device, or having had surgery in the last year. And that's consistent with what's been seen, that invasive interventions and a lot of healthcare exposures tend to be predisposing factors. Patients to be included did have to have lines in the period surrounding the time that the CRE was identified. But because of the retrospective nature of the data collection, we don't have access to information on how long those dwell times were overall. So we don't know, for example, for how many days or weeks patients had a central line or a Foley catheter or other devices present. And we don't necessarily know what practice was across the whole spectrum of facilities that contribute to this data. I work in the healthcare system that had, at the time of this collection, 4 hospitals contributing to this. So I know that based on this data and other internal data we've gathered, that there has been an ongoing push to remove these devices when they're not necessary. And the finding of those strong associations really underscores the importance of doing that. But I don't know what widespread practice was in the area at the time.
I'm always interested to talk to other IPs or infection preventionists at hospitals and see how they approach getting rid of indwelling devices, because it is very important, not just for CRE, but, infections in general. But now that we're discussing predisposing factors, let's talk about some fixed ones. The article talks about that most incidents were female. Do you think that was because of urinary catheters? Females are more likely to have a urinary catheter?
I think that's certainly possible. We saw that roughly 57% of the cases of CRE in this cohort are in women. And I think that there are more easily available alternatives to urinary catheters sometimes in hospitalized patients who are male. And so I think that it is a potential contribution there, that you are more likely to see urinary catheters in women. We had fairly stable rates of urinary catheters in the population who had CRE solely in the urine and the population who had invasive infections, but those rates were high in both. They're over 50%.
I'd like if any of our listeners have used the external urinary female urinal, they should email us and let us know how that goes. So if you're listening out there and your hospital uses those female external urinals, let us know. I want to know how that goes. And I had another question too. I've got so many questions about all the fixed predisposing factors. Why do you think most incidents were in Black? Was it Black women or?
So the racial breakdown is overall, including both men and women. And we did see that 51% of the patients in the cohort were Black, which is an overrepresentation compared to the metro Atlanta area as a whole, where it's about 33% of the population is Black. And I suspect that is a reflection of other racial disparities related to some of the predisposing conditions. So, for example, patients who had chronic kidney disease or were on dialysis or were diabetic were heavily represented in these cohorts. About 44% of patients with CRE had diabetes, more than a quarter had chronic kidney disease. And those conditions likely in turn increase someone's risk for healthcare exposures, antibiotic exposures, the kind of device use that we're talking about being a risk factor here. And we know that there are big disparities in this country with respect to race and the prevalence of those conditions. And so I suspect that's what's driving the overrepresentation by race in the CRE cohort.
Sure. And the more we get into these studies, the more we kind of highlight that difference. Now, that doesn't tackle invasive infections that you all looked at. In the invasive infections, it looks like most were male and younger. Is that correct? And if so, why do you think that is?
That is correct. And I think that it's hard to know, but there may be a couple of contributing factors there. With respect to age, I think it's possible that part of that is driven by the fact that we saw a lot of urinary either colonization or infection with CRE in long-term care facility residents, and that may in turn be driven by indwelling catheter use in that particular population, but that population does tend to be older. And so that may be why we were seeing an age difference between those with urinary colonization or infection and those with invasive infection. I think also some of the things that were associated with invasive infections here were more aggressive medical interventions, so central lines, multiple indwelling devices, and things like recent surgery. And those may be interventions that we tend to be more aggressive about in younger patients. And so I think that's possibly a mix. And then in terms of gender, I think we may again be seeing the impact of urinary catheters and the tendency toward initial urinary site in women. Mm-hmm. And then I think, again, we may be seeing gender differences related to some of the risk factors that drive these CRE infections. So, for example, there's data that while you may have more women than men with chronic kidney disease, men tend to progress faster towards more advanced renal failure and needing renal replacement therapy. Mm-hmm. So you may see more dialysis and more central lines in the male population.
That makes sense. Because I know the article talked about trying to progress faster from central lines to, a dialysis catheter to an AV fistula. So trying to make that switch earlier on in their care. So that makes sense.
Thinking about different types of patient populations, the article also talked about long-term care facilities and the patients, and whether CRE was detected as only in the urine or as these other higher severity infections. So, what did you find as you looked at that patient population, and were you at all surprised by those findings?
What we found was that being in a long-term care facility was associated with having CRE in the urine rather than with invasive infection with CRE. And I was initially a little surprised because long-term care facility residence is such an established risk factor for CRE infection in the literature. But I think we again may have been seeing a couple of different contributing factors. I think one is that because we don't have that data on how long a catheter was in, it's possible that the long-term care facilities do have longer dwell times of those catheters, that there may be people who almost permanently have one while they're in the facility, and that may predispose them to urinary colonization, and that may be what we're picking up. I think the other thing that's possible is that the long-term care facility may be where people acquire colonization with CRE, and that may be why it's so often associated with its presence, but that it may be the more invasive interventions or broad-spectrum antibiotic use that we see in acute care settings that really pushes people to progress from colonization to infection and then invasive infection with CRE. And so it may be less common to see those infections in a long-term care facility environment than in a hospital.
Yeah, because usually when we think of high-risk patients, we do think of our long-term care or like elderly patients as being in this high-risk population for most things. So I find that is really interesting that it was not, you weren't detecting those more invasive infections in these patients, but also probably a good thing.
Yes, although I think my suspicion would be that they may acquire it there because we know what all the risk factors are of long-term care facilities, to your point, and that then when they are hospitalized, maybe when the pressure is applied with antibiotics or with devices that give it an inroads, and that may be why we then see some of those invasive infections subsequently. Because a large percentage of the people who had these infections in the hospital had a history of long-term care facility residence or got discharged to one.
Interesting.
Okay, so let's talk about infection prevention when it comes to CRE. You talked about the highlighted need for hand hygiene. What are some of the, let's talk about infection prevention and how important it is. Go ahead and hit us with it.
I think that this really highlights that is the critically important intervention here because it's the thing you can change. a lot of these patients are so sick that they need these devices, or they need to be operated on, or they need to be in a facility for that higher level of care. So some of those risk factors on an individual patient level aren't going to be modifiable, but how we approach those devices once we're in, the fact that we do hand hygiene before we access them, that we do appropriate dressing changes, that we get them out as soon as we possibly can, that we do appropriate skin prep when we do surgery, that we do perioperative prophylaxis appropriately when we do surgery. Those things are modifiable. And so I think knowing that these are our risk factors and that certain patients are particularly vulnerable and at high risk, that's where we really want to target those infection prevention interventions, because that's where we may have a real impact.
Absolutely. Preach it, sister. We've got hand hygiene, taking out our lines, antimicrobial stewardship, of course, which is interesting because once you get into antimicrobial stewardship and we talk about empiric inclusion of CRE, which I'll ask in a little bit, but also screening patients, right?
Yes, and I think that's a really interesting question. The current CDC CRE toolkit says that you should absolutely screen in the setting of a suspected outbreak in a healthcare facility. I think that what this study may highlight is there may be very targeted opportunities to do additional screening, depending on what potential you have for other interventions. So you mentioned a minute ago that one of the things we mentioned in the article is that if you have somebody who's very high risk for CRE, so let's say you've got a transplant patient who's got a permanent indwelling line, who got operated on in the last year, who's living in a long-term care facility, and who we just gave 3 weeks of vancomycin to as broad spectrum therapy. This person is clearly a setup to have CRE in the future. So if there's somebody who starts to need dialysis, they should be a first priority to not have an indwelling line, to see if you can create an AV graft or an AV fistula. So in that setting where you might be able to intervene or do something differently about their clinical care, that might be a population where you really could, in future studies, identify your highest risk people and then pick those where you might change something about your approach and do screening. I think that would also be true as we learn more about whether there are ways to eradicate CRE colonization. So I know there are researchers, including here at Emory, looking at fecal transplant for that purpose. And so I think if we ultimately had a way to get rid of it in people who are colonized with it, then it makes more sense to look for it. And then I think in the patients where you might approach their specific treatment differently, so where you might give them different antibiotics, different surgical prophylaxis in a very high-risk setting, then you might want to look at screening in those purposes too.
So when you're talking about screening, would you say for these high-risk patients, you would potentially want to do any sort of culturing type screening to detect CRE in either potentially colonized patients as they're coming in, or to prevent, potential transmission, within your facility if there are patients of unknown CRE status?
So I think you would definitely want to do the latter kind of screening of patients coming into your facility if you knew you had an outbreak kind of setting. So if you knew that you had a local long-term care facility that had a high rate and you were admitting people from there, or if you were worried based on seeing an unusual cluster of cases that you were in some way having transmission within your facility, those would be the times to do screening, probably rectal swab cultures on patients. Other screening beyond that hasn't been well validated, and I think it's a very interesting area for future study, because I do think for individual patients, if you have a clear way if you think they're high risk for CRE and you have a clear way they would benefit from knowing whether they had CRE, so you would approach something differently about their overall clinical care, you would approach something different about their antibiotic selection, you would, for example, try to eradicate their colonization before something like a transplant. If you were in those kinds of settings, I could see it having real benefit, but we need to know both who do we target that screening toward, and what are we going to do with the results? Where are our real points of intervention? And then I think that would be something important to look at in studies.
Yeah, I think that makes a lot of sense. I have seen some work around doing similar things with C. diff patients. So certain areas of detection for high risk C. diff patients, and then actually setting up some mitigation practices to put in place for prevention, so sort of preemptively thinking about how we can manage these high-risk patients. So it sounds like maybe more research has to be done, but that this could be something that could be useful for other infections, including CRE, to prevent them from occurring in our patients as we're providing quality care.
Yes, agreed. Because I think with C. diff, there are people who've even looked at prophylaxis during other antibiotic treatment or during certain invasive medical interventions like bone marrow transplant in people who are at high risk or who are colonized. CRE is a little trickier with empiric treatment because the problem with CRE is there's not much out there to treat it with. But I do think, not that you don't always want to be careful about your lines and your indwelling devices, but being able to flag who those people you're most concerned about and think about where your interventions could lie, I think is an important area in the future to look at.
So let's talk about something else that you talked about in the article too. Empiric inclusion of CRE coverage in patients that have, multiple invasive devices, lines, or certain preoperative patients. I think, the term empiric antibiotics is going to give some people cause to kind of hold their breath a little bit. So let's talk a little more about that. And
sounds good. It always gives me palpitations a little bit too. I used to be our antibiotic stewardship director at the University Hospital, but I think that where we need to focus is that antimicrobial stewardship doesn't always mean fewer antibiotics or lower spectrum antibiotics. It means making sure the right patient gets the right antibiotic at the right time. And so there is a very small group of patients who need very broad spectrum antibiotics because of what they're colonized with or what their risk factors are. And so I think that these kinds of studies where you look at your patient population and figure out what those risk factors are can be important in that setting. So I think from a perioperative prophylaxis situation, if you had a patient you knew was colonized with CRE at the site where you're going to operate, so somebody who's got CRE in the urine and they need bladder surgery, somebody who's got known GI colonization with CRE and you're going to operate on their colon, you really might think about targeted perioperative prophylaxis to cover that so that you do not develop an invasive infection in the setting.
It makes sense. Yeah, that makes sense.
And then I think in terms of other empiric coverage, for the place I really think about this is in patients with sepsis, because I always, when I'm prescribing in the hospital, I'm thinking about my margin for error. And if you have somebody who has a urinary tract infection and is an outpatient or is on the regular floor and is very stable, you can get your culture data back and target your antibiotics to it. If you have somebody who is crashing on 3 pressors in the intensive care unit, you've got much less margin to be wrong about what you give them, or they're going to die if you don't have the right antibiotics on board to manage what is an overwhelming infection. So in that population, when you're picking what you're going to give them, we talk about all the time, somebody who's coming in from the community probably, and with no medical history, probably doesn't need coverage for resistant gram-negatives and CRE. But somebody who's been in your hospital for the last 3 months, who came in from a nursing home, who's got 3 lines, has had 4 broad-spectrum antibiotic courses, and they crash on you, that's somebody where you start to think about double coverage for resistant gram-negatives and or potentially even coverage for CRE. I always do a risk-benefit calculus in those situations of how high risk do I think they are for something really drug-resistant, and then how much margin for error do I have?
Yeah. And that's patient-centered care. That's what medicine is, keeping the patient safe and tailoring it to their specific needs, doing your screening and doing your risk analysis. So that makes a lot of sense. I think that'll help some of our listeners and us feel better about the word empiric when we put it in front of antibiotics.
Yes, definitely not giving empiric CRE coverage to everyone.
Yes, and I greatly appreciate the sort of further defining of what antibiotic stewardship looks like. It's not just the fewer antibiotics, but being thoughtful about the antibiotics and dosage and duration and all of those things that are all incorporated into stewardship.
Right.
So I think as we close out today, we'd just like to know what you think are some of the key points that our listeners should take away with them when thinking about CRE and patient care.
I think the main one is that while a lot of the time they're necessary, it really is our interventions that cause CRE, colonization and infection. So it's the things we do to patients. The surgeries we do, the hospital admissions, the devices we put in, the antibiotics we give them. And so what that means is that it's our responsibility to do those things as safely as possible, because that is what will prevent the CRE colonization and infection that is preventable, both broadly from a public health perspective, but then even in an individual patient who may be colonized, at preventing them from progressing to infection or invasive infection. So it is these things like continuing to ensure our hand hygiene is good, continuing to follow protocols both for device insertion and device maintenance, trying to get these devices out as quickly as possible, watching what antibiotics we give to the patient, when and for how long. Anything that we can modify to help address this problem has both benefits for individual patient care and for overall public health.
Yeah, absolutely. Couldn't agree more. Well, thank you so much again for taking the time to join us today to talk about this extremely important research. I think Nicki and I can both say we definitely learned a lot from this paper.
Mm-hmm. Yeah. Thank you, Dr. Sexton. We really appreciate it.
Thank you very much.
We are Nicki Shorr and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC, and APIC staff Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller.